Good morning, everyone. Today I'll be talking to you regarding the glued IOLs. The glued IOL is a proven method of intrascleral fixation. It's one of the proven method and provides an optimal results in secondary IOLs. The key to the performing the glued IOL is one need to measure the white to white diameters to gauge the amount of haptics which are available for scleral tucking. The tucking of the haptics in the intrascleral is the most important surgical step to get the stability of the IOL in glued IOLs. The prerequisites are two. Any three-piece IOL, you require preferably foldable IOLs. The other is a tissue glue, which needs to be, you need to have these two things to do a glued IOL. Like in any other secondary IOL, one need to do a corneal endothelial evaluation, pachymetry, look for vitreous in the AC, evaluate the iris, angle, capsular evaluation should be done, on the posterior segment evaluation. Like sutured scleral fixated IOL, here also you need to make it ideal optimal sized scleral flaps approximately 180-degree apart. The size of the flap should be optimally around 2.5 to 2.5 mm the width. And you can use the markers, either the toric markers or now glued IOL markers are available for making these scleral flaps. Why the size of the scleral flap should be optimal. Two large flaps, sometimes you may have a lesser amount of haptic, externalized haptic for scleral tucking. If it is a too small flap, sometimes you may find it difficult to tuck the haptics into the pocket. The sclerotomy should be made beneath the scleral flaps, and they should be 180-degree apart, so that the marking should be very proper. Improper sclerotomies sometimes can lead to the decentration of the IOL. The first I will be telling you the theoretical aspect, then I'll go to the video. The IOL unfolding is the most critical aspect. It should be slow and gradual. The three-piece IOL should be loaded in such a way that the tip of the haptic, the leading haptic should be outside the cartridge when you enter the AC, so it is easy to grasp the tip of the IOL. Once it is there, then slowly inject it for the maneuverability. Start injecting the IOL inside the anterior chamber once the tip of the haptic is grasped to prevent the IOL drop. So the leading haptic should be grasped properly at the tip. Do not pull the tip of the haptic before the entire IOL unfolds in the eye, so sometimes it can damage the IOL and the haptic. Haptic maneuverability, typically what has been described is by a handshake technique, one should externalize the haptics. But do not hold the IOL at the mid shaft. But if you hold at the mid shaft and pull it, sometimes the haptic can break or kinking of the haptic can happen. Sometimes you may have to explant the IOL and redo the whole procedure. Anterior vitrectomy, it is very critical for any secondary IOLs. It should be properly, vitreous should not be there at the sclerotomy site as well as in the pupillary area. The haptic tuck, you need to, after creating the flaps, you have to create an intrascleral pockets using either you can use a 26 gauge needle or you can use a bent MVR blade, 1 mm blade to create an the one thing you should be careful in these patients is don't make a too thin scleral flaps, because it can expose the haptics once you tuck it into the sclera. Of course, the glue application, the couple of things I would like to say in glue application: keep the area dry before you apply the glue. So switch off the infusion. Either it could be pars plana infusion or your anterior chamber maintain. It has to be shifted on, and air can be put into the anterior chamber. So it keeps the area very dry, and you can put once you tuck the haptics, you can put the glue under the scleral flap and proceed. Even the conjunctiva also can be closed with the clear corneal incision, and conjunctiva both can be covered with the glue. Let me show you a video of the glued IOL, whatever the steps I described now. Key here is the marking of the 180-degree opposite angles, opposite axis, because if any decentration leads to the decentered IOL, so make the optimal size scleral flaps, lift up the scleral flaps. Then approximately around 1.5 mm behind the scleral flap. Either you can, if you're comfortable, use a pars plana infusion, or you can use an anterior chamber maintainer also if someone is not comfortable with the pars plana infusion. Make sure that the cannula is inside the eye. Make a sclerotomy, use a 22 gauge needle. Your direction of the needle should be critical, because you may damage the iris if you go too anteriorly also. Keep the volume of the chamber and the eye very taut so that it should not be hypotony while doing these maneuvers. Sometimes it can bleed. The preferable to have a 3-piece foldable IOL. Many companies do that. Preferably, many use either Johnson & Johnson or an Alcon 3-piece IOLs. Once you get the leading haptic, the tip is seen. You should, from the sclerotomy, use grasp it and externalize it. Keep slowly injecting the IOL. Don't pull at one go because you may damage the haptics. So externalize it. By handshake technique, the other haptics also is externalized. Make sure that the first haptic should be held so that there should not be any snip back of the first haptic which has been externalized. Slowly pull it out. Make an intrascleral pockets now and tuck it into the sclera and apply the glue. Tuck it in, switch off the infusion so that the area should be dry. Then apply the glue, close it. So the main concern here is some of the challenges when you face is when the eyes have got a large white to white diameter or large eyes, then the limitation imposed by the commercially available IOLs may not fit into this. So you need to do some certain modifications in a large eyes or with a large white to white. We call it as a 5-pronged approach or a 5 techniques which we can adapt. One is, instead of doing an horizontal glued IOL, one can do a vertical glued IOL by sitting on the temporal side. That's the one thing. And you can make a sclerotomy little bit anterior. Typically, you tend to make it around 0.5 millimeter instead of 1.5 millimeters. Sometimes if you do 2 anterior sclerotomy and the glued IOLs, the optic capture incidence is very high. So you may have to do a pupilloplasty to prevent the optic capture because of anterior placement of the IOL. Then where area which you are entering anteriorly, 0.5 mm, that area we can do a peripheral iridectomy to prevent the iris incarceration or creating an iridodialysis in that area. Of course, the fixation of the trocar anterior chamber maintainer helps in these eyes. So the vertical glued IOL, as I told, instead of horizontal 3 and 9, you sit at 6 and 12, you have to do the glued procedure. Anterior sclerotomies, it can made at 0.5 mm, but the one thing is you should not push the needle too hard when you make an anterior sclerotomies at 0.5 mm because it can cause an iridodialysis. There is a vitrector assisted peripheral iridectomy done when you are doing an anterior sclerotomy. Instead of 1.5, if you are going around 0.5 mm, make a small cutter assisted iridectomy in those areas. Small eyes, of course, the concern is not the externalized haptics will be too lengthy. One may have to trim the haptics to tuck the iris into this haptic into the thing. The pupilloplasty role I told, if it is sometimes there is an optic capture risk, so one need to do a single pass 4-throw pupilloplasty in these patients. We had published this article way back. It's my own article published in JRS in 2012. In this article, basically, I compared the glued IOLs with the sutured IOLs. This study mainly highlights the suture-related complications of the scleral fixated IOL, how it can be overcome by using the glued IOLs. So this is an initial study which is done way back in 2012. So the key steps in glued IOL is, one is the handshake technique. The glued IOL technique can be combined with many of the surgical maneuvers like corneal procedures, or it can be used as a scaffold for a dropped nucleus or an intraocular foreign body. There is a less incidence of posterior complications. There is a less chance of pseudophacodonesis in these patients. So intrascleral haptic tucking is the most critical part of it. So IOL related complications, this is a study with one of the studies which shows that it is more with the rigid IOLs than with the foldable IOLs. Even the optic capture, IOL decentration, haptic displacement, subconjunctival haptic extrusion, all these occurs with the rigid IOLs more than the foldable IOLs. These are the complications, both anterior segment and posterior segment complications, starting from glaucoma to ERMs, detachments, all these have been compared in the patients with the glued IOL. Even the second surgery rates are more with the rigid IOLs than the foldable IOLs. So as I told, it can be combined with endothelial keratoplasty procedures because you need an IOL support for most of these procedures for air tamponade. So you can combine glued IOL with the corneal endothelial procedures. Scaffold, of course, definitely is. Thank you for the patient hearing. I would like to say one can adapt the secondary IOL fixation of your choice based on your expertise and skills. Thank you once again.